Hello. Welcome to the National Lipid Association's Lipid Podcast. My name is Dr. Peter H. Jones, and I'm your host today. And we're coming to you live from the 2026 MNLA annual sessions in Chicago. And I am very fortunate to be able to have as my discussant today a very good friend from many years and a well-known lipidologist known as Dr. Lipid on social media, and you can find him just about anywhere because of his great discussions and great graphics that he tends to put out there and his own podcasts. It's Dr. Tom Dayspring. Tom, thank you so much for being here.
Oh, anytime, Peter, to get to meet and talk to you again, I will be there. But I'm here in Chicago because the MNLA bestowing on me that super high honor and master of the MNLA. So, wow, I would have never.
Congratulations. Well deserved, Tom. That is the master designation is the top of the organization, and not many people make it. So congratulations, and you well deserved.
Thank you.
And as I also need to add in here a little bit, happy birthday. This is your birthday weekend too. So
it is. Yesterday, I started my 80th journey around the sun. So
that's wonderful.
As I always tell my audiences, happy lipiding. So I've paid great attention to my lipids over the years, and I'm still here.
And we're still here. Both of us are still here. That's awesome. Well, you know, we've got a topic you've spent a lot of time discussing in a variety of ways. And it's one of the things that way back at the beginning of my career and yours too, you know, we knew there were two major cholesterol particles in our blood, and one was called LDL cholesterol and the other was HDL cholesterol, and LDL was the bad cholesterol. But we didn't think that HDL did anything like LDL did, so we said, oh, well, no, it's not bad. It must be good, okay? Well, as this little thing we hand out here at the MNLA says, HDL, people just don't understand me. And the bottom line is, yeah, HDL is complicated, and can't really call it the good cholesterol anymore. So in the short amount of time we've got, why don't you tell us what we need to know about where we are with HDL and how we look at it?
Yes, and indeed, as you know, it's a complex topic, but and HDL is different from all of the other lipoproteins in our plasma because the apoprotein that surrounds the other lipid-carrying particles is apolipoprotein B. We have the very low density, intermediate density, low density. Postprandial, we have chylomicrons coming out of the intestine. So that is one group of lipoproteins. They originally were called beta lipoproteins before they even knew what ApoB was, because they migrated with beta proteins in the serum. So any non-ApoB containing lipoprotein is in this high-density lipoprotein classification. And the structural peptide that is different on an HDL than the ApoB, it's apoprotein A1 is the structural protein. So HDL particles can actually carry from 1 to several, 4 and rarely 5 copies of ApoA1 per particle. So we have the alpha lipoproteins, the ApoA1 particles, the HDLs, and we have everything else that's not an HDL is a beta lipoprotein, the ApoB particle. So in the early days when none of this was really understood, all they were measuring were cholesterol. So they could measure total cholesterol. They could start measuring HDL cholesterol directly. LDL cholesterol, other than very sophisticated analyses, had to be estimated using various formulas for that. So that's where those cholesterol metrics came out of. But all of the early epidemiology, so all that ApoB cholesterol, whether it's VLDL cholesterol, LDL cholesterol, and it's mostly the latter, that's what winds up in the artery wall generating plaque, hence bad cholesterol. Right. And like Peter says, well, the HDL cholesterol epidemiologically using observational trials did not seem to correlate. In fact, it inversely correlated with atherosclerosis. So therefore, the cholesterol in the ApoB particles, the LDLs, is bad. It's going to kill you. But the cholesterol in the HDLs is obviously not contributing to your plaque. And the early theory was, wow, so if we could just raise HDL cholesterol, like we've been lowering LDL cholesterol, we would really blow away atherosclerotic disease. Right. And it was a reasonable belief.
It was, yes.
But then you have to do clinical trials. and one drug after another that raised HDL cholesterol, wow, there's no MACE reduction even when we seriously raise HDL cholesterol.
Right.
Then came Mendelian studies where we could look at genes that are associated with HDL cholesterol, and there was no correlation, high HDL cholesterol, low there was no genetic signal that HDLs were causal of coronary disease. So we began to understand HDLs at a much higher level. So here's a fact I like to drop on HDL podcasts. I've just explained the total lipoproteins that are floating around your body. You have the ApoB family, but you got these really tiny dump trucks called HDLs. You know, in a centrifuge, they sink to the bottom. That's why they're called high density. Whereas the ApoB particles float towards the top. The big ones, the VLDLs, Carlos, are really at the top. LDLs are in the middle. They don't sink as much as HDLs. What determines the buoyancy of a particle in a centrifuge? It's lipid mass.
Right.
So the particles that carry most of the lipids float, the ApoB particles. The particles that carry far less lipids, they're basically carrying proteins. They sink.
Right.
So that's where, if you're using density to separate these particles, HDLs have the highest density. And even within the HDL group, there are bigger HDLs and really small HDLs. The bigger ones carry more cholesterol than the little ones do. And you can subtype HDL particles, and the classifications get very tricky, and a lot depends on how you're assaying them as to what you call them. You know, Bob Rosenson put together a world panel probably 10, 15 years ago, where he stopped with this alpha 1, alpha 2, alpha 3, HDL2, HDL3. Let's just call them very small, medium, large, and very large HDL particles. And actually, the HDL population, all of them are floating around our bodies. Here's another factoid. HDL lipoproteins are 90% of the lipoproteins floating in anybody's plasma. The ApoB particles make up 10% of the particles. But what are the particles carrying the most lipids, the most cholesterol, the most triglycerides? The ApoB guys, because the volume of the sphere is a third power of the radius. So all the lipid molecules are in the big lipoproteins. So that tells us Mother Nature had other chores for the HDL other than to carry an eensy-weensy bit of cholesterol compared to the ApoB dump trucks or so. And it turns out that it's really, some of the cholesterol they carry is important. Not that it really correlates that much with HDL cholesterol in a useful clinical sort of way, but it's all the other things they carry. What else do they carry? Over 200 proteins have been described in proteomic studies with it. Now, look, HDL is a little dump truck. No HDL can carry 42 proteins. But if you have 90% of your particles are HDLs, we have tiny subgroups of HDLs. This group carries a couple of proteins. That group carries different proteins. That group carry different proteins. And the same with the phospholipid makeup on their surface. This group has very crucial phospholipids. That group has different phospholipids. And both the proteomic and the lipidomic, meaning the phospholipidomic content of HDLs, is truly what determines what we're now calling their functionality. So, Peter, you ask, what do HDLs do, Tom? I don't know, but whatever they do, it's related to, do you have functional HDLs doing what they're supposed to do? Or is Tom or any patient's HDLs ill-equipped with the right type of proteins or phospholipids, and therefore they're not performing their very useful chores, or they're really hindering those useful chores, so-called dysfunctional HDLs. Outside of research labs, you and I at the bedside in the clinics, there are no really good HDL functionality tests that tell us in totality all the numerous aspects of HDL functionality. And it's not only helping efflux from cells, it's carrying coagulant proteins, anticoagulant proteins, antioxidative proteins, immunological proteins. So HDLs are, Dan Rader taught me a long time ago, they're part of the innate immune system because they are helping deliver these immunoproteins that some white cell created or something, and they bring them to the site of the pathology to maybe help put out the fire. So this is why they're so darn complex.
Wow, that's amazing. And what makes it unique for them to be so important in carrying so many of these other proteins? Is it the presence of the ApoA makes it more reasonable than the ApoB containing lipoproteins, that they don't carry as much? What's unique about them?
That's part of it. Remember, one of the proteins that they all carry is apoprotein A1. It is, unlike ApoB, a transferable apoprotein, so they can jump between particles. And even chylomicrons carry a little bit of ApoA1 as they come out of the gut, and then they release them, so you get free ApoA1 in the serum. But ApoA1 is a helical protein. It's called MER22. That means each loop has 22 amino acids, but those amino acids could be different in one loop compared to another, and that determines what it's going to bind to the ApoA1. Okay. So at the basic level of constructing the helical loops of ApoA1, the loops are a little bit different. We're not talking about apoprotein little a tonight, but there's kringles on apoprotein little a, and these kringles will carry different things. So ApoA1 will bind with greater affinities to this protein or that protein or so. Or this one has a real affinity to, hey, I'll carry some of the cholesterol. So that's what it really comes down to. Now, the phospholipids, when ApoA1 starts to mature from just a protein into, it's a precursor for what ultimately is going to be a mature HDL particle, the first lipid it acquires is phospholipids. Okay. That's called phospholipidation. And then almost at the same time or just afterwards, they start lipidating with free cholesterol. So this little ApoA1 becomes phospholipidated and cholesterol lipidated. But remember, the ApoA1 is what we call an amphipathic protein. One side is soluble in water that floats in plasma, but the other side, which is going to develop surrounding the core of the lipids, is hydrophobic, lipophilic. So when ApoA1 gathers phospholipids, that stays right on the surface. But if free cholesterol binds to it, it has to make it go into the core of the particle to make room for new free cholesterol to bind. So it's so cool. There's an enzyme that joins with ApoA1 called LCAT, lecithin cholesterol acyltransferase. And this is why I love biochemistry, Peter. So that enzyme, when free cholesterol jumps on ApoA1, grabs one of the fatty acids on the phospholipid leg, usually lecithin, lysophosphadylcholine, and it steals the fatty acid and it sticks it on the third carbon of the cholesterol molecule, changing the amphipathic, the partly water-soluble cholesterol, into a totally hydrophobic molecule called cholesterol ester, which changes on one side of the ApoA1 to the other side, and that's how the balloon starts filling up. It starts to lipidate. And before you know it, you don't have such a tiny itsy-weetsy HDL. That's where the large HDL was. It's lipidated. So HDL2, as it used to be called, in Rosenstein's, it's the large HDL. If you don't have large HDLs, you have a low serum HDL cholesterol. So for the people doing advanced lipoprotein metrics, if you ever see the large HDL particle concentration is low, I will guarantee you that person has a low HDL cholesterol, because it's the large HDL2 cholesterol that drives the total HDL cholesterol metric. Right. So, and in the overwhelming majority of people, why wouldn't people have large HDLs? Because triglyceride gets transferred into the HDL from VLDLs and kilos, CETP, and all of a sudden, to make room for trigs, the HDL has to send cholesterol back the other way. So now you have triglyceride-rich, cholesterol-poor HDLs, and trigs don't last long. Various lipases, hepatic lipase and endothelial lipase, hydrolyze them. You got an eensy-weensy baby HDL, which can be grabbed by a couple of receptors in the kidney and catabolize, and you can pee away your amino acids, or the kidney can release them, and free ApoA1 goes right back into the circulation again. So that is quickly the dynamic remodeling of HDL particles. It's in large part triglyceride driven.
Yeah, that's the remodeling from CETP. But the other part, we were talking about being able to take cholesterol and esterify it and put it in HDL. We always referred to that as sort of reverse cholesterol transport. It picked it up from cells, and it would be able to take it, and then it would get delivered back to the liver, so the liver could decide what to do with it, put it in the bile, do whatever it needs to. So is reverse cholesterol transport still a reality? Is it important?
It is a reality, but as you started off there, it's a heck of a lot more complicated. It's not just the HDL sucking cholesterol out of this cell or that cell and zipping it back to the liver. This is going to be a shock to most people. So if you told me what your HDL cholesterol level is, in general, 60% of that HDL cholesterol came out of your liver cell. Your hepatocyte is the major lipidator of HDL particles. The second major lipidator is your enterocytes in your small intestine. That's another 20 to 30%. Only 10% of the cholesterol that might be in your HDL particles was ever sucked out of a peripheral cell. You know, peripheral cells don't overproduce cholesterol in most circumstances. They make just enough for they don't have a big need to get rid of it. But if they did make it, they have to get rid of it because it would crystallize and kill it. So a little bit does come out of your peripheral cells,
Right.
but it's the minority.
Right.
So that before I tell you what reverse cholesterol transport is, I'm going to introduce a new concept, forward cholesterol transport.
Okay.
So when the HDL fills up, it's a big, fat, mature HDL particle. Your HDL cholesterol is higher than it was. What does it do with that cholesterol? Pit stop 1, steroidogenic tissue. They are the major suppliers of our gonads and our adrenal cortex, which of course need a lot of cholesterol to produce steroid hormones. So pit stop number 1, we have a storage organ for cholesterol in our body called adipocytes. Everybody thinks they just store fatty acids, triglycerides. No, they're a massive cholesterol. So the adipocytes have a receptor, scavenger receptor B1, that can delipidate HDL particles. They actually produce CETP, which can help delipidate HDL particles. The adipocyte's the only other cell other than the liver that produces CETP, by the way. Wow. So pit stop number 2 is give your adipocytes, save a little cholesterol for a rainy day in case we need it in a big hurry. And now the third thing is the HDL could indeed go back to the liver. The scavenger receptor is in the liver. It could grab an HDL, delipidate it.
Right.
You know, it's the same thing we believe is true in the small intestine. They can grab the HDL particle and delipidate it. So an HDL bringing cholesterol back to hepatocytes or enterocytes is called reverse cholesterol transport pathway 1. It's direct reverse cholesterol transport because HDLs are doing it. But here's the second major pathway. This big fat HDL full of cholesterol, remember, it's by far way more numerous than LDL particles. For every LDL particle you have 37 times more HDL particles. So using something we've already mentioned, cholesterol ester transfer protein, HDLs and LDLs collide. HDLs carry hepatic-produced CETP, and it becomes erect on the surface of the egg. You can use that metaphor for whatever you want, but that erect CETP can now puncture any ApoB particle, 90% of which are LDLs, and while they are connected with this little bridge between the two particles, the HDL sends cholesterol to the LDL or even a VLDL that got punctured sends triglycerides back to the HDL. Your puncture goes away, it becomes flaccid again and binds to the HDL. So we've already told what happens when the HDL gets triglycerides. It's going to get catabolized and become a baby HDL again, or even eliminate it renally. But now, what do you do with the LDL that just sucked out a lot of cholesterol from, oh my God, that's driving one of the things that drives LDL cholesterol levels way more than people imagine. So the LDL's got two choices. It could crash the artery wall, taking that good cholesterol
over there,
suddenly made it bad again. Now that's an absurd. But the LDL, if the liver is expressing LDL receptors, or if the gut is expressing LDL, they can internalize the LDL particle. So when an ApoB, mostly LDLs, return cholesterol, half of which they got from an HDL, to the gut or the liver, That is called indirect reverse cholesterol transport. So if somebody asks me, Tom, what is reverse cholesterol transport? It's the sum of direct HDL mediated plus indirect ApoB mediated.
Okay.
And you and I can't measure this. This is why when, Peter, if you told me what your HDL cholesterol level, I could care less. Because you said, now, Tom, what's my reverse cholesterol transport? I said, Peter, we'd have to put you in a metabolic ward, inject you with radioactive cholesterol, and see what is going on in your body. We're not going to do that. So I get so annoyed when doctors see high HDL cholesterol and they tell people, you've got great reverse cholesterol transport. Think about it. If you really did, why would HDL cholesterol be going up? It should be being delipidated. So we have to stop using these terms, oh, I'm helping your reverse cholesterol transport. The last part of that story, and one of the crucial parts of HDL function, is HDLs are very tiny. They can go in and out of the artery wall. And here's a macrophage full of cholesterol, a so-called foam cell. All the ApoB particles got internalized, and now that's what's contributing to plaque. And HDL, hopefully a smaller one, can bind to receptors ABCA1, cholesterol efflux transporters, and there's a G family too, that efflux cholesterol out of your plaque into an HDL, which returns it to the serum and does what I just, it has numerous pit stops it could make. But hey, you're sucking cholesterol out of the artery wall. Rader first described that, and he called it macrophage reverse cholesterol transport. But Dan, and I love him for this, said, doctors, you hope you have functional HDLs are doing that, but the amount of cholesterol they suck out of your plaque contributes 0 to your total HDL cholesterol level. So again, you cannot use HDL cholesterol to ascertain what HDLs are doing or so. So people, go back to what Peter said, I don't know what they're doing. I pray you have good functional HDLs. And right now, I believe the best way of doing that, pharmacologically, we're not there yet, is to proper lifestyle, reduce inflammation in your body, get rid of the ApoB particles, and maybe get rid of, God forbid you have any inflammatory disease, your HDLs are start behaving a little more functionally. The good old Mediterranean diet maybe comes into
That's
play.
awesome. One other thing I would just want to touch and see what you think about, but there was always a discussion possibly that HDL served to help the body deal with and move and clear bacteria or viruses. Is that a true thing or not? Does it help with that kind of immune?
It does, and it's even the LDL receptor. You know, certain bacteria, certain viruses can even bind to ApoB particles. The HDL is part of the immune system. So yeah, getting pulled into or delipidated by the reticuloendothelial system or even the liver of the gut, it's just all of that flux of these particles is part of the immune system or so. But again, I have no way of measuring that.
It's just
everything. And it gets very complicated to truly understand that. So even for those of you out there in all these fancy-dancy HDL subparticle tests, there's one use to them. Look, if you are measuring large HDL particles and you don't see them, then you can almost judge if HDL cholesterol is down and triglycerides are even an itsy-weetsy little bit up. You're doing what we've already described. You're catabolizing your HDL particles. So a lack of large HDLs, and, you know, hey, it's also in the presence of small HDLs or VLDL remnants. They're all lipoprotein signatures of insulin resistance. So that's the only use for those subparticles. But, you know, I think if you looked at ApoB or non-HDL cholesterol and HDL cholesterols, you can pretty much assume you're dealing with insulin resistance.
And you improve insulin resistance, you probably should see changes in the correct direction.
The last thing I want to say about this advanced testing, because it's always getting more complicated, because there's it looks to be an incredible drug coming. It's one of the latest CETP inhibitors, obicetrapib. And those drugs, by inhibiting that CETP, HDL particles become massive because they can't delipidate. So, of course, HDL cholesterol goes through the chart. You not only have 8 big HDL2 particles, they're so big it's the rarely seen HDL1 particle. Normal humans don't have them because we don't make our HDL so big. But if you're inhibiting CETP, you're going to wind up with that. Now, look, at least this class of drugs and its predecessor, anacetrapib, looks like they do reduce coronary artery disease, almost certainly because they're pretty good ApoB lowering too.
Yes.
And you don't make a heck of a lot that they're raising your HDL cholesterol to 130. But there are observational trials that do suggest cholesterol of 130 might be a signal of dysfunctional HDLs. So if you're creating that high HDL with any FDA-approved CETP inhibitor, I don't think you have to worry about that too much. But here's where you do have to worry, because a lot of people are doing NMRs. And this comes right out of the mouth of their inventor, Jim Ottfos. So HDLs normally on an NMR, biggest one is 13 nanometers in diameter. Now, the smallest HDL is 18 nanometers in diameter. But if you have HDL1s, all of a sudden they start approaching 18 nanometers in diameter. So when you do NMRs on somebody on a CETP inhibitor, the HDLs block the spectral signals coming out of the small LDL. You get a false positive small LDL p-test. June and Jim will tell you, the inventor of NMR, anybody on a CETP inhibitor, ApoB has got to be your marker of atherogenic particles. Don't look at NMR-derived LDL particle concentrations, because they're being camouflaged by the big HDLs. And you'll see in some of those trials, they report OB is really reducing small LDLs.
Yeah. Be a little wary of that. Yeah.
It's funny, the ion mobility, which is how Quest measures, they don't even report small HDLs because they separate particles not by spectral signals, by electrophoretic changes. And they know once you get to the wrong surface charges. So they don't report total HDLP. They only report large H. They have a decent signal that it's validated. So be careful when you're using HDL particle metrics. It requires a little education.
That's awesome. Listen, this is a complicated topic. We've got a lot to learn about HDL. It's not as simple as we used to call it, and I wish people would quit referring to it as the good cholesterol. It's not that simple, and we need to focus on what we do know works. Bad cholesterol, reduce that, the LDL as much as possible, ApoB containing lipoproteins. But listen, any last thoughts about where our listeners can go to learn more about HDL? Do you have places that you discuss this, or do you have any publications?
So they follow me online. I've actually got some nice review summary publications, so you can find out how to contact with me, and I can share those references or so. But it requires a lot of reading, and even the guidelines have nice chapters on HDLs. But if you go through the guidelines, or you can see how they're changing. And for all these people who think they have to raise HDL cholesterol, never, ever in the history of organizational lipid guidelines has there ever been an HDL-C goal of therapy.
Correct.
So why are you wasting energy trying to raise HDL cholesterol? Concentrate on what you just said, Peter, the ApoB particles, however you're measuring them.
Exactly. I think that's wonderful. Tom, you are a genius, and you're awesome to talk, and you had a great discussion today, and I really appreciate you being with us, and I really appreciate everybody listening in. Thank you.